first we have Dr. Niamh O'Connell, Director of the NCC. Niamh.
Well, I'm sure, I hope everybody here on the line knows me by this stage, but if you don't, I'm one of the haematologists here in St. James's. Sorry, I'm just trying to get my screen sorted out here so that I'm not staring at myself. So I gave an update to the EHC recently on surgeries and procedures in people who are now on Hemlibra. And Brian thought it would be useful for me just to review that again. And I'm delighted that I'm also going to be joined by Alison Dougall, who's also well known to everybody, in terms of particularly discussing procedures in the mouth in relation to dental extractions and other procedures, because this is an area that is of particular interest, as you'll see in a minute. And we need the experts on this one, and we need the specialists to assist us. So I'm delighted Alison can be part of this webinar tonight. So I suppose one thing just to remember is that when we think about managing surgeries for people with haemophilia, the bleeding risk relates to the person themselves, so whether they have a severe, a moderate or a mild deficiency, and what the actual level of their factor is. So for example, if you've got factor 7 deficiency, you know, anything above 20% or 0.2 will be reasonably protective for a surgery, and you might not need treatment at that level. So just to make that point that, you know, the factor level can be important. And then finally, we've got the person's own history of bleeding. So often you'll have people who've had a number of different procedures in the past, and we can think about how they've responded to those surgeries or procedures to help us to understand what their risk of bleeding might be with one that's coming up soon. And then when we think about what kind of procedure the person is having, you know, there's different bleeding risks associated with different procedures. So, I mean, I don't think, you know, it'll be too difficult to understand that if you're having certain procedures, maybe, you know, procedures in certain areas like the brain or something like that, then you'd have much lower willingness to have a bleed associated with that. The type of anesthesia, in other words, whether you're having a local anesthesia injection or you were thinking about an epidural or a spinal anesthesia or a general anesthesia, and then, you know, whether or not you're going to allow somebody to have anti-inflammatories. And of course, for people with bleeding disorders, we'd always want them to have the selective COX-2 inhibitors like our Coxia rather than the standard ones like Difene. And there are guidelines, they've been updated, I'm sure everybody knows this recently, so they're absolutely comprehensive. One of the things that's interesting actually about surgery though is that we have this table of the levels that we should be aiming for people who have haemophilia A or haemophilia B. Interestingly, they give us different targets depending on whether you've got lots of factor available, such as is the situation in Ireland, or you're in a country where you have less access to factor. But in any event, they give us some ranges about levels that we should be aiming for before the surgery and for the first few days after surgery, and then more distant from the time of the surgery. Funnily enough, they have lower levels for factor 9 deficiency, which I have to say we wouldn't go along with. We would tend to treat people with haemophilia the same, whether they're A or B. And then obviously for minor procedures, it's a little bit less, of course, in terms of the duration of treatment and maybe the target levels. But I think one thing that's important to know is that these sorts of numbers have come really out of custom and practice rather than from definite evidence or clinical trials. So even the WFH would say that more research is needed to evaluate these practices that I suppose we have in place. And it's not to say there's anything wrong with it, because this is what we have been doing for many years, but just to alert you all, I suppose, to the idea that, you know, it's not as cut and dried as you might think when we think about how long does somebody need to have factor for, or how much factor do they need for a particular procedure. I suppose when we think about treatments that are non-replacement therapies like Hemlibra, there's two kinds of potential advantages. I suppose the first is that we might not need to use as much factor, or maybe we might need to use any factor or hemostatic treatment for a particular procedure. So that's a possibility. And the other thing is that maybe we don't need to give treatment for as long, because if you can imagine, if somebody's in hospital on Hemlibra, they have a surgery, we give them some factor treatment to cover the procedure. Once we discharge them home, they're still on their Hemlibra, so they potentially still have some protective treatment on board even after they've stopped getting their factor infusions. So just to talk about Hemlibra, I'm sure everybody here knows, but it's a subcutaneous treatment. that mimics the effect of factor VIII in the bloodstream, but isn't factor VIII. It's not a treatment for acute bleeding, so we can't use it to treat surgeries or prevent bleeding after surgeries. And I suppose the question is, while it gives, when you are on Hemlibra and it gives some protection from bleeding, is that sufficient on its own to gain hemostatic control, for example, in minor surgeries? So this question, I suppose, has been looked at a little bit in the people who participated in the phase 3 clinical trials. And everybody might remember that there were 4 different trials. Haven 1 was a study of people with inhibitors. Haven 2 was a study in children with inhibitors. Haven 3 was a study in people with hemophilia A without inhibitors. And Haven 4 was looking at a slightly different dosing schedule, again, in non-inhibitor patients. And as it so happens, there were a number of people who had surgeries during these 4 studies. So in fact, there were 233 surgeries in total, of which 18 were major surgeries. So major surgeries are defined as things that, for example, you have to open a body cavity like your chest or your tummy, or a major joint like replacing a knee, for example, or a hip. Or a surgery with a very high bleeding risk, like resecting the mucosa of your esophagus or gullet. These are all things you can imagine would be major surgeries. And then minor surgeries are the kinds of things that would not involve, for example, opening a cavity or getting into a joint space, or typically a minor surgery wouldn't involve an admission to hospital or might only be admitted overnight and wouldn't need prolonged factor. So we divide them into major and minor. So there was a small number of major surgeries and a bigger number of minor surgeries. And that mirrors, I suppose, to be honest, what we would find in our normal week-to-week practice here in the NCC. We'd have lots of minor procedures and some major procedures. I suppose one thing to know is that about a third of the people who participated in the studies ended up having a surgery. So clearly some people had more than one procedure. And if we go on and just think about it in more detail, I want you to remember that the surgical procedures, the treatments for those were determined by the person's doctor. So it wasn't that everybody was following the same plan. I think I've already explained that, unfortunately, there isn't really very firm evidence one way or the other on exactly how much treatment any one person might need for a particular surgery. So we don't really know. There might have been variations from place to place in the kind of treatment people got. So for most people who had major surgery, that was 18 of those, and there were 18 patients, about 83% of them had treatment with factor, and most of those had no bleeds after the surgery. 1 person needed extra treatment for a post-op bleed, and 2 people had some kind of bleeding but didn't need additional factor. But actually, interesting, there were 3 people who were managed without clotting factor. Although I would point out that these ones down here weren't, at least to my mind, particularly major procedures. So surgical removal of the synovium, yeah, that's getting there, I suppose. A reduction of a fracture is just resetting a fracture, and a muscle suture, like neither of those particularly strikes me as being major. And then I suppose the bigger number of procedures were minor surgeries. So if we look across the top here, we had a fair number of dental procedures. There were also 34 surgeries where they removed a central venous access device, such as a port. 30 people had some kind of a tummy scope, which again would be a very common one we'd see here. 25 people had minor procedures on their joints, typically joint injections, and then there was a collection of other procedures. And many of these actually didn't receive any additional factor. So in fact, 2/3 of the doctors treating these patients decided not to give them any additional treatment or factor for these procedures. And I'll just draw your attention to these particular categories. So you can see that 23 out of 25 of the CVAD procedures, all of the endoscopies, 11 out of 12 of the joint procedures, and 41 out of 45 of the other procedures didn't have any bleeding. So these were people who were just on their Hemlibra, didn't get any extra factor, and had no bleeding. So that's, I think, interesting in and of itself. And I suspect maybe that the investigators, you know, I suppose we were aware of some of the clotting complications that occasionally did occur in people on these studies, especially where bypassing treatments like FIBA were used. So I suppose maybe the investigators were particularly conscious of that and were trying not to give too much extra factor. I'll just point out also the dental procedures, and I'm going to highlight these because Alison is then going to, I suppose, probably give you a more expert review of the bleeding after dental procedures, but I'm just going to mention them and then Alison will come back to them. So there were 64 dental procedures that didn't have, there were 42 dental procedures that didn't have prophylactic clotting factor. And while a good number of them didn't have any bleeding, there were a significant number of bleeds, and it shows a little bit better here as well. So if you had a dental procedure on Hemlibra during these studies, about a fifth of people who didn't get clotting factor had a post-procedure bleed, but actually about a fifth of people who did get factor also had a post-operative bleed. And so I suppose that's a little bit alarming because that seems like too many people having bleeds. We didn't have full information really about things like how much tranexamic acid or cyclocapron were used, or what kind of measures were used during the procedure to reduce the chances of bleeding. But we know that maybe an antifibrinolytic agent was used in 28 patients. And this is just, again, those ports. So looking at those in more detail, because that's a very common one, particularly for the kids on Hemlibra, and that's a good thing, being able to have your port removed because you don't need it any longer. That's brilliant. So of the 25 procedures who didn't get clotting factor, 1 had a bleed, and 9 procedures where they did give factor, 2 of those patients had a bleed actually. So it's interesting that it can occur with both. I suppose there's a few little health warnings here. I suppose these studies weren't designed as a surgery trial, so they weren't set up to see and capture all of the surgeries and manage those in a standard way. And only a third of participants had a surgery, so I don't know whether those third of patients were different to the other 2/3. We don't know that. And as I've mentioned, particularly around the dental, where this is very important, we didn't get a lot of information about what was being done in the mouth to prevent bleeding and what other treatments like cyclocapron, etc. were used. There's a couple of reports in the literature at this stage about people on Hemlibra having big surgeries. So there's one here of somebody who was 54 years of age on weekly Hemlibra who had an inhibitor. So that person had a hip surgery and had treatment with Novo 7 until day 14, and thankfully had no bleeding, didn't require transfusion. And in fact, interestingly, it had a previous joint replacement earlier in their lives where they had gotten a bypassing treatment and needed a lot longer in terms of bleeding support or hemostatic support. And then there was another report from Italy of a similarly aged patient also with an inhibitor, also on weekly, also having a hip replacement. Again, being treated with Novo 7.
Sorry, 1 second, Niamh. Sorry if there's some background noise. Could you all mute if you're not speaking, please? Just mute until Niamh is finished. Thanks.
I won't mute. Is that okay? So this person from Italy was a very similar story to the first patient. No, in this case, actually, while they got through their surgery quite well with Novo 7, the next day they developed a bleed in their thigh. But because the treating team knew that their inhibitor titer was quite low, they were able to switch to factor VIII replacement for a time until that antibody increased again. And then they switched back to 7A and cyclocapron. So I suppose just goes to show that maybe you need more than one treatment in your back pocket if you're dealing with an inhibitor patient undergoing a major surgery. And this was another report of a patient who was undergoing surgery. And on this one, the team who were treating him looked at an assay called a thrombin generation assay to see if they could figure out, was Novo 7 going to be sufficient to normalize the clotting system? So on this graph, you can see that this is the person's curve without any treatment on board. So it's not quite normal because the normal is this line here. So it's good, but it's not quite normal. If you took somebody who has an inhibitor and you did a thrombin generation test without any treatment on board, it would be very flat. It would be down here. So at least the Hemlibra is doing something, but it's not quite normal. But when they gave Novo 7 at the dose that would be similar to what we'd given surgery, you can see that it becomes very similar to the curve. And then if you increase the dose of Novo 7, it starts getting too high in a way. So anyway, this reassured the team treating this patient that they could use use the normal doses of 7A. And indeed, they went on and they did a knee replacement. And these are all the doses of 7A that the person got. And thankfully, the person was able to recover well and not have any bleeding and be discharged. And then finally, there's a bigger group of mainly pediatric patients that have been published. So a total actually of 93 patients, which is a very good number of patients, of whom 19 had an inhibitor. And they had quite a few minor procedures, mainly port removal with a few dental procedures and other things, and then 2 major procedures. And in this one, for the major surgeries, in this case, they gave factor VIII replacement and they didn't have any bleeding. For the port removals, there was a bit of a mix and match. So some people got a dose of hemostatic treatment on 1 occasion, some people got 2 doses, and 5 people got no hemostatic treatment for the port removals. And as was kind of found a little bit with the port removals earlier on in the Haven studies, there's always 1 or 2 people who will bleed whether you do or you don't give cover, it seems. And then finally, we've got our own experience. So I suppose we've had people with inhibitors on Hemlibra since September of 2018. I have to get my dates right now, 2018, yeah. And then we've got people without inhibitors who've been on Hemlibra since December 2019. And inevitably over time, we end up doing procedures for these people because things come up and we have to get on and do it. So we've done surgeries in 10 people on Hemlibra. A total of 18 minor procedures and 9 major procedures. So quite a few procedures actually, even in that short time. This is just a list of the various different kinds of procedures that we've done. So you'll see lots of scope tests. They tend to be pretty common in our center, and also the joint injections. And we've certainly done some central venous access device removals and insertions and port removals and so on. But we've done some pretty big surgeries, including, you know, things like a discectomy, or 2 discectomies actually, esophagectomy, tonsillectomy. So some quite major procedures there too. The good news was that we were able to get everybody through surgery without any bleeding. We did have some delayed bleeding though, so this is bleeding that occurs after we've stopped replacing the treatments, if you like, the factor treatments. But most of those were explainable in a way. So there was somebody who has hemorrhoids who had repeated bleeding, and that's not unusual with that condition. You can band hemorrhoids, and then when the bands fall off a week or 10 days later, you get bleeding. So that's not too surprising in a way. Somebody else was getting dressings for a particular kind of problem called a pilonidal sinus, and unfortunately just forgot to give their factor before a particular dressing change. So that was just something that can happen. Somebody else had delayed bleeding from a feeding tube. And again, when you have something that's, you know, a device or a tube that's in the body, it can move and maybe that causes bleeding. And then finally, we've taken out 1 port in the adult service, and we did have some delayed bleeding after that, unfortunately. But again, you know, our pediatric colleagues in Crumlin have taken out a number of ports now without any additional treatment, and they've not had any bleeding. So I think it can be a little bit variable. And there's lots of different guidances for us, but I suppose they're all more or less based on the same information that I've just shown you. So in the end of the day, I think we have to have a practical approach. So the first thing is that your haemophilia treatment center or comprehensive care center really need to be absolutely in the picture for any procedures for people on Hemlibra. We need to know what you're having, when you're having it. We need to work with you and your surgeon to make sure we've a plan in place for giving treatment and how we're going to manage if there's any bleeding unexpectedly. And it's important that we do monitor the person not alone on how they're doing and whether they're bleeding, but also there's some particular ways to monitor treatment in especially those people who don't have inhibitors and who are on factor VIII replacement. So we've got to do that, and we need to know about that in the lab. So for inhibitor patients, we take the view that, look, we certainly should know what the inhibitor titer or the level of inhibitor in the blood is, because if it's below a certain level, we can use factor VIII treatment as our backup, and that's useful for us to know. For minor procedures, we don't always need to give treatment, but there's no clear guidance, so we're just going to have to talk to you if you're having a minor procedure, and we'll see whether you do or you don't need treatment, whether we think we could manage just with tranexamic acid, or whether we need a little bit of treatment like Novo-7. For major procedures, we definitely would use Novo-7 as our first-line treatment, but we have a few different options for second-line treatments. And again, we'll need to just talk those through with each person, and some of these might not be suitable for every person. So I think we'll just have to have a chat with people if they're having a surgery. And then for non-inhibitor patients, the same, I suppose, approach for minor procedures, that it's about checking to see what the procedure is, whether we could manage just with tranexamic acid or whether we think we need a small amount of factor. For major procedures, we will use a Locta. We will want to get your level above 50%, and we have to measure that treatment with a special test that we have available in the lab, but it wouldn't be available in every hospital. So that's why it's still very important that we coordinate all of that treatment from here in St. James's. And remember, we already have some experience. So we do plenty of surgeries in people with mild factor VIII deficiency. And I suppose a rule of thumb might be, you know, thankfully Hemlibra converts people from having a severe bleeding phenotype into having a milder bleeding phenotype. And so I suppose I also sort of think to myself, well, what would I be doing if this was a mild patient for a major or a minor surgery? And the other thing is that we also need to think about, well, how acceptable is it for people to be having post-procedure bleeding? And at least to my mind, I think it would be important that we try and prevent any bleeding at the time of the surgery. There's a certain amount of delayed bleeding that I think, you know, we might have to just accept, in the sense that it'll always happen. It can even happen to people who don't have haemophilia. So just, you know, we would really want to probably try and focus on making sure that we don't have bleeding around the time of the procedure itself. And I suppose the other thing, I suppose, that's in the back of all of our minds is that, you know, if we have people who have a milder bleeding tendency, the other thing about hospitalized patients having surgery is that they have a risk of clotting, clots in the leg, clots in the lung. At the moment, we don't use routine preventative treatment for clotting in people with severe haemophilia, but I think this might change over time, again, as we get more experience with this. So I'm just sort of putting that out there as something that we're keeping in our minds. So we would like more evidence, though, and I think, I suppose one thing I would sort of say is that, you know, in the NCC, with the partnership that we have with our patient community, I think we as a centre and as a patient group are well placed to provide this real world evidence. So I think that's something that we really probably should be doing for our whole global community, is trying to give them some guidance on this, because as I say, even in the short time that we've been using Hemlibra, we already have quite a bit of experience with the procedures. So just to say thank you very much, everybody, for listening this evening. And I'd like to hand over now to Alison, who is going to talk with great expertise and knowledge around dental procedures.
Thank you very much, Niamh. We'll take questions for you both at the end then. So, Alison. So, Alison, you're still muted.
Great. Is that okay?
Yep.
Great. Okay. Hi, everyone. So I'm here because I think this is, to a certain extent, a real, and it's a really important point for us in dentistry, and I'm going to talk to you about why I think it is. I think it's a real time when treatment could go one way or another. And I remember this about when I first came to Ireland about 15 years ago. And I had very little experience with treating patients with haemophilia at that point. I'd done it theoretically, seen a few patients. This was the first time when I'd been in a big centre. And it was a real advantage because I was able to look at this with new eyes and look at all of the literature that was out there, because as Niamh said, all of the dental protocols were based on custom and practice that had happened for years and years and years. And what I realized was there was very little evidence. But what I learned at that point from everybody and from the research that I did was that patients with haemophilia are scared of dentists, and dentists are scared of people with haemophilia. That was true then, and to a certain extent, that's still true today. Not a lot has changed. Also, what I learnt is from the PROBE study, which was a big patient-reported study, an international study, was that patients who had experienced what they considered life-threatening bleeds, the majority of those were from the mouth. So this again is a particular thing that's important about the mouth. And what I learned about my own research when I did the qualitative studies and all those series of interviews was that how horrendous it is for people to experience a bleed from the mouth. It may in fact not be life-threatening, but it's perceived as being life-threatening because of the taste of blood, because of the visual part of blood. Lots of people with haemophilia very rarely see their own condition, but in the mouth, spitting blood, swallowing blood, blood on the pillow is a real visual reminder. So I think that bleeding from the mouth is particularly distressing. What I also learned was that people with mild haemophilia in the past, before treatment was well organized, also experienced significant bleeding. So when I look at literature like Niamh has presented, where people say, oh, 1/5 of people had bleeds, or there was bleeding from the mouth, I don't think that people with haemophilia trivialize that, because in reality, that is traumatic for the patient, traumatic for the family, traumatic for everybody around. It results often in people avoiding dental care, any type of dental care. It scares dentists, apart from the blood loss or whatever. And I know that I'm speaking to people who've possibly in the past experienced that, because people never forget it. And I know that this history is a barrier to oral health. And I know that now, because of the fear of the past or the fear of those stories in the family, patients and dentists need really proactive advice to manage their oral health. We're at a pathway where we could go one of two ways with this, depending, looking at what's coming out the literature. But I've also learned that trust takes years to build, seconds to break, and takes a long time to repair. So regarding our dental protocols with Hemlibra, I think it's very important for us as clinicians to get this right for patients. And I think that Hemlibra offers us some fantastic advantages for dentistry. But at this point, I possibly am going to be a little bit more, risk averse is the wrong word, but a little bit more wary than people might think. So let's go back historically. In 2009, I published a brand new protocol, which was, you were all involved in this. This was the protocol where you stopped having to have factor every time you went to the dentist. Previously, whatever you were doing, you went and had your factor from Aideen or from Anne O'Sullivan or whatever it was, and then you went to the dentist. We looked at all the protocols. I'd been in Ireland for 2 or 3 years. I looked at the evidence and we developed this brand new protocol, and that's where we stopped. That's where we went to low factor protocols. And at that point, we developed, as Niamh said, protocols for people with severe bleeding types, mild bleeding types, platelet defect functions, patients on anticoagulants, because we realized that this wasn't a one-size-fits-all, that everybody needed, that all the dental protocols needed to be different depending on severity. This year published were the WFH guidelines for the management of haemophilia. I was the dental expert on these, and I had to do a huge literature review and look at everything that had ever been written about dentistry over about the last 30 years. And we published this, and this was actually the thing that has really crystallized my thinking. What we did was we looked at every single research that had ever been to try and work out the best evidence that there was for dental protocols. And we looked at everything, and we were shocked by just how little detail there was in all the evidence and all of the protocols. Every single dental protocol in every country was different. And in the literature that we looked, we could never tell from the data that was published who had severe haemophilia, who had mild haemophilia, whether teeth being taken out were wisdom teeth, whether they were loose teeth, whether they were baby teeth, whether there was any other medicine. So what we were able to get from this literature search was really a statement that going forward, we need to do better, because the protocols that have been up until now have been based on consensus, on what we've learned. And of course, with Hemlibra being a new drug, we've got very little to go on. But what this paper did show very, very, very clearly was that the protocol that we've been following in Ireland for some time was the best that was out there, in that we looked at the protocols that had bleeding following dental extractions, from protocols where they had just factor before the extraction, like we do in Ireland. And we compared that, we pulled all the data to look at protocols like they have in the States, for example, where somebody having tooth out will have 2 lots of factor the week before, 2 lots of factor the week after, and there was no difference in the bleeding rate. So what we looked at is that throughout the world, looking at all the protocols, the average bleed rate for having a tooth out with haemophilia is about 10%, 1 in 10. Barry White always used to say to me, it's about 1 in 10. Now, in Ireland, our bleed rate is probably at the moment about between 3 to 4%. We've got the lowest bleed rates that I've seen. And I think this is because in Ireland, we very, very strongly advocate for the use of oral tranexamic acid, cyclocapron. Not only do we rely on factor, we have a very stringent protocol that means anybody having surgery or anything that's going to bleed, all of our patients, except for the very few who can't take them because of stomach problems or because they've got a thrombosis risk, all have cyclocapron. And we've learned that we've brought our bleed rates for dentistry right down. We not only use less factor than most other places, we also have the lowest bleed rates, about 5%. And during COVID, we had a 0% bleed rate. And I think that's probably because I was monitoring people so closely, reading them. So what we learned from here is that people are doing lots of things. We can't quite work out what works and what doesn't, but what we saw was what we're doing at the moment is we're doing well. And what we learned also was that we can, like we've always used, stratify our dental procedures into these green, orange, and red. And I think for those people on Hemlibra, nothing's going to change much as regards, because the risk of a procedure is the same. So in the green box, we've got the go-ahead, dentures, fillings, small injections, this sort of thing. At the moment, that is go ahead whether you've got severe haemophilia with an inhibitor, mild haemophilia, whatever, that's go ahead. This middle one, which is the orange one, is the stuff at the moment, the cleaning that we do just under the gums, where we can, you know, put clamps on your teeth, and where we're doing kind of things that go below, or sort of deep cleaning. Now, at the moment, with our people with severe haemophilia who are taking factor beforehand, or who were perhaps not taking any factor, this is where we would say to people, do this on the day that you take prophylaxis, or do this on the day after you take prophylaxis. So we've got a nice peak level going on. I think the difference here for people with Hemlibra that I found now for many of you is we don't now need to say to you, do it on the day or the day after, because we've now got this nice level, predictable amounts. So these orange procedures that we never ever with our mild or our severe haemophiliacs would give extra factor, but we would perhaps adjust timing. So I think the advantage for now with the patients who are taking Hemlibra, because we're not looking at peaks and troughs, is the fact that we can just carry on, and these things are carry on as normal. And I think that Hemlibra is giving people at least 5 or 6%, probably more than that, but that's more than enough for these orange situations. And I think we can learn that from the past with our mild patients with mild haemophilia. Where it gets interesting, and this is where we're going to start discussing, is these red procedures. And these are the procedures which carry a bleeding risk. Now, it's not only in haemophilia they carry in risk. This table is the same for patients, for example, taking anticoagulants, you know, people who are at risk of strokes, for example. So exactly the same. And this includes root debridement. That's where we're doing the really deep cleaning for somebody who's got gum disease, where their gums are bleeding a tremendous amount and they've got pocketing. This is a bleeding risk. This is somewhere where we would always, with severe haemophilia and often patients with mild haemophilia, we would encourage patients to have factor for something like this, which carries with it a bleeding risk. The periodontal surgery, again, this is where people are having gum surgery, is quite a significant bleeding risk. Why gum surgery is a bleeding risk is because it's very vascular, lots of blood vessels there, but also because we are doing that gum treatment specifically because the gums are inflamed, because there is inflammatory tissue there, and we know that inflamed tissue bleeds. So it's actually the fact of probably the inflammation, even in somebody without a bleeding disorder, these kind of procedures bleed quite a lot, perhaps for 5 or 6 minutes. An implant placement, again, is something which carries with it not a life, but it carries with it bleeding risks. And extractions carry variable risk. Easy to take out, simple teeth. Say we're taking them out for people to have braces. No inflamed tissue, nice clean extraction. This is a really fairly low risk. It's still a bleeding risk, but it's not a high risk extraction. We can completely contrast that where we're taking a loose teeth out, where the gum is really inflamed. Again, that's something that we find is much more of a bleeding risk. Then we've got submerged wisdom teeth, we've got multiple teeth. So what I'm saying here is that it's not one size fits all. So when, I'm going to move through, so when we start seeing data coming from those trials that say we can't make sense of this data because some of them bled, some of them didn't bleed, it's the fact that there is such a difference between the procedures that are being carried out. This is not a homogeneous thing that's happening. This is a very different thing from happening. So where do our protocols put us at the moment? At the moment, the recognized sort of consensus world protocols say that to have an ID block, that's quite a deep injection that we use very occasionally, but we use it when we take back teeth out or when people need very deep fillings on back teeth. At the moment, we say that patients need 30% levels to stop them getting a hematoma. Now, those patients who get a hematoma are very few and far between. But when it happens, it's not very nice. People can't open their mouth. They have, bruising. They have swelling. So my question here is, at the moment, if this is 30% levels that we're requiring, is this something we are happy to go ahead with someone in Hemlibra? Now, the question here is, we at the moment don't know exactly how much factor, but this is the consensus that's been used over the years. The trial that would need to be done would be that we would need to do injections and then do an ultrasound afterwards, so we could see if there's any bleeding there. But at the moment, the protocols say 30. For extractions, in that big research sheet that I showed you, the review article that we got pushed, the protocols generally asked for extractions to have between 30 and 50% before people had an extraction. And that was giving about a 10% bleed rate. For us, you know, less than that because we're taking care. For patients having periodontal surgery or implant placement, excuse me, let's go back. We're talking about having up to, again, between 30% and 50% here. Now, the question that we don't know at present is how much factor you actually need to have that tooth out, because these figures here are allowing for the fact that that factor is going to drop over the next couple of days. So these levels are to allow for the drop that happens the day after to stop you getting hemorrhage. We know that we can take teeth out at levels that are a lot less than this, but we still aren't sure exactly how low we can get. There are lots of papers from Australia that tell us we can take teeth out with no factor replacement, but those are with very skilled surgeons in very controlled places. And at the moment, people have been saying a minimum of 30% for teeth out. Now, adding tranexamic acid, which is going to stabilize that clot afterwards, means probably practically we can achieve dental extractions a lot lower than 30%, as long as tranexamic acid is used. Remember, the international level of bleed rate following a tooth is about 10%. We're using tranexamic acid, we've brought that down to about 3%. So we know that's very, very promising. So what do we know at the moment, and how is this going to inform what we're going to do in Ireland? Well, at the moment, the thing that is really good is that we now have stable levels. So we perhaps will be able to, in the future, look at being a little bit more, let's say, adventurous, but within a very high safety, you know, in a place of safety. Remember, trusted everything. We don't want bleeds for people having teeth out. It's not positive for anyone. But because we've got these stable levels, we may be able to consider in the future that we can, you know, we can consider some teeth out with only tranexamic acid if they are incredibly simple teeth, or for example, things like deciduous teeth, baby teeth. However, there is not enough data at the moment for us to be able to say, like some of the protocols are coming out in France or Italy, to say, Hemlibra is the magic bullet. We can now take teeth out. You can take up to 2 teeth out. For us and for myself, I believe at the moment that what we should be saying is that anyone who needs any of those red procedures should have a personalized management plan in conjunction between a dentist and a hematologist, who's going to say how difficult the tooth is, if there's any inflammation there, if a patient has got factor at home, for example, to manage if there is any post-operative oozing or anything like this. But I think that it is certainly, whatever is being said internationally, this is not the time to say Hemlibra is something that means that you can have red procedures without any kind of another thought. If we look at the data that we've got from the trials, and as I say, Niamh went through it, we've got about 64 extractions to look at. Sadly, none of those detail whether the ones that bled were surgical wisdom teeth, whether, for example, they were very inflamed, whether the patient was a smoker, whether any so all of those things add to bleeding. And why we do so well with our dental data, I think, our dental extractions in Ireland, is because we give meticulous post-operative instructions, things like the smoking, the diet, the use of the right pain relief, the use of vasoconstrictors when we're taking. So there's lots more to whether a tooth bleeds than whether you've got factor or whatever. So regarding those, the questions that we keep getting asked was, why did some bleed with tranexamic acid? Why did some not bleed with tranexamic acid? Well, we know that from the literature. We know that that's probably whether the dentist used the local measures in the socket, the packs, the sutures, and again, how difficult the extraction was, and how difficult and how inflamed that area was. So we cannot at the moment deduce from the data exactly why things bled, but we can make a really, really good guess at that. So do we trust the current data? I have to say that from the dental data coming out of the Haven trials, we are mining it at the moment. We're trying to go back and get the actual data right from source, rather than the kind of rather than the short form that was put in the papers, to see if we can get some more data and critically find out why the ones with Hemlibra bled. Why did they bleed? What was the current thing? Was it that they were all surgical wisdom teeth, for example? The other reason I don't trust the current data is because I know you guys too well. And I know that quite a lot of the patients, perhaps, where the data said they didn't bleed in Hemlibra, was because the patients treated themselves at home. And I know that that happens, and you'll smile to yourself because you know that you do it yourself, and you've told me you do. So for me, to actually have any faith in the data at the moment that says Hemlibra is the silver bullet for dental extractions, I don't think that we have enough data, enough control over the data to know if people treated themselves before or after, if they had any bleeding. We also know that some of the data said there was no bleeding, and then we look at the data and find that actually the patient had factor 2 or 3 days later, but it was down as a no bleed. So I think we've got to, in Ireland, because we do so our dental extractions so carefully and so and with so much collaboration between hematologists and dentists together, I think we're going to be a big player in sharing the data. Our only problem in Ireland is that we're now so good at looking after teeth, and you guys are so good at looking after your teeth, we hardly take any teeth out. So this is difficult for us to collect the numbers. So where are we going forward? I think going forward, we can very confident on these yellow procedures, the deep cleanings, all of the endodontics, the root canal, all of this thing. I think we can be incredibly confident that teeth, that these can be done with no special measures. I think the red stuff is still at the moment going to be a personalized dental plan, and only the very simple extractions would be considered suitable for Hemlibra alone, but never Hemlibra alone. It's going to be Hemlibra plus tranexamic acid and meticulous local measures. And if we believe that there's any inflammation tissue or any risks, then I think straight away there's no advantage in not using factor, because the last thing we need at this point. But going forward, we've got quite a nice study going to be happening where we're actually looking at a consensus for the management of patients going forward for dental procedures. We're going to collect all of the hematologists who's worked in the Haven trials. We're going to collect expert patients and dentists together to come up with a standardized dental protocol, which we have consensus on, but also consensus on the data that we need to collect going forward, so that we can actually inform the evidence base and collect good data going forward, so that if something bleeds, we've got the exact data that we need to collect as to why that adverse event. And bleeding from the mouth is an adverse event because it's really traumatic. So I think where we need to go going forward is we need to be conservative but not worried about going forward, but we need to now collect some decent data so that we can inform people going forward, so that we don't end up with bleeding incidents. We know that people with haemophilia who are perhaps 40 and over have got great intravenous skills. They know how to manage bleeding. They've seen bleeding, so they can manage a bleed. But people coming forward who perhaps are never going to know life without Hemlibra may not have those skills to deal with bleeds, and nor may their local A&E. So I think that's where I am at the moment, and I think that's we're all haematologists in. James is very excited about how this is going to open up treatment going forward for dentistry and mean that people can really confidently have the basics, really confidently have their teeth cleaned, really confidently have root canal, really confidently have some, know that if they need teeth out, we've got a good protocol for them. Do I think it's the silver bullet for dentistry that's going to free us all from the dental bleeds of the past? Evidently not. From the trials, 1/5 of teeth taken out bleeding to me is quite high odds at the moment.